Hello friends, welcome to my channel Pathology Master. Myself Dr. Parth Goswami, I am the consultant pathologist and today I will teach you few MCQs. So today we will discuss case and image based MCQs and this question bank is from the Hematology section. So today I will cover the MCQs of the Hematology section. There is a 10 MCQs in this test. So let's start the quiz. So we will start with our first MCQ. 22-year lady presented to you with a complaint of the weakness. There was a complaint of fatigue and weakness. Her routine investigations was done, and in the CBC the hematocrit was 27%. So obviously it is low. So your PCV value is decrease. The MCV is 66. The normal range of mean corpus volume starts from 80. So the MCV is low. The RBC count is 5.9 million. You might remember the normal range of RBC count, that is from 4.5 million to 5.5 million. So here again the RBC count is high and the RDW was 12, so it is within range, and the serum ferritin was 50 milligram per liter, that is again within the range. So this is your abnormal values, and based on this value you have to diagnose the case. What's your probable diagnosis? So first option is iron deficiency anemia. So guys, remember the case of iron deficiency anemia. In the iron deficiency anemia, the hemoglobin count is obviously low. But because of less hemoglobin, the RBC count is also the low. Here the RBC count is increased. So it could not be the case of iron deficiency anemia. If here RBC count is decreased, then it could be case of iron deficiency anemia, because in the IDA, PCV, MCV, hemoglobin all are low, but RBC count is not low. So first option is excluded. The second one is megaloblastic anemia. Obviously, in the megaloblastic anemia, the maturation, nuclear maturation is delayed and MCV is high. MCV reflect the size of red blood cell. So MCV is high in megaloblastic anemia. So again, this is not the case of megaloblastic anemia. Third option is thalassemia minor. So the thalassemia minor is one of the hemolytic anemia, and the patient is usually asymptomatic. Patient will complain only fatigue and weakness. He or she doesn't need a blood transfusion. And in the thalassemia minor, because of hemolysis, there is a presence of extramedullary erythropoiesis. Compensatory erythropoiesis is there, extramedullary, and so your RBC count is high in thalassemia minor. So this is the case of thalassemia minor. So your right answer will be thalassemia minor. Obviously it could not be leukemia, because in the leukemia such findings are not seen. So this is your first MCQ. Remember, whenever the RBC count is high and the hemoglobin, MCV value all are low, but RBC count is high, then your case is thalassemia minor. And you can calculate the Menzer index as well, that is MCV divided by RBC count. If it is less than 13, then your case will be thalassemia minor. And guys, calculate the Menzer index here, it is around the 11, so it's a case of thalassemia minor. Now second MCQ. A 21-year male patient got in road accident. His hematocrit was 32%, but after 1 day it reduced to 28%. So obviously it might be because of blood loss. Ultrasonography revealed that there was a presence of liver injury and the hemoperitoneum. The blood was collected in the peritoneum. That's why hematocrit was suddenly reduced 4%. So which was repaired by the surgeon. They have drained the collected blood and they have repaired the liver. The CBC was performed after 4 to 5 days. So it will reveal which of the following finding. So guys, this answer is very easy. Whenever you have the blood loss, your compensatory mechanism is getting activated and the bone marrow will produce more and more blood. That will produce the more red blood cell because you have lost it. So whenever the bone marrow is doing more RBC production, the premature cells of the red blood cells can be released in the blood, and that is the reticulocytes. So your reticulocytes count will obviously high whenever you have the blood lost. So the reticulocytosis is suggestive of the blood loss, and it is a compensatory mechanism that happens after 2 to 3 days or might be start immediately. So after 4 days you will reveal reticulocytosis in your peripheral smear. These three answers are the wrong. Reticulocytosis is indicative of the bone marrow activity, and because of loss of blood in the peritoneum, collected blood in the peritoneum, there will be compensatory more RBC production, and some more reticulocytes will be released in your blood. So reticulocytosis is the answer for this MCQ. Now MCQ number 3. 25-year African male patient having the brown color urine after the intake of aspirin. Peripheral smear examination reveals the Heinz body, and on supravital staining bite cells were seen. What could be probable diagnosis? So guys, here the two important point is presence of Heinz body and presence of bite cells, and there is a presence of brown color urine. So obviously it is a case of hemoglobin urea, and the urine blood is present. So it could be because of hemolytic anemia. And these three are the causes of hemolytic anemia: malaria, G6PD deficiency, and the IDA. In the IDA, usually hemolysis is not present. So you can exclude the iron deficiency anemia and the MDS, that is myelodysplastic syndrome, as a cause. So here you have confusion between two causes in the malaria or G6PD deficiency. In the malaria, black water fever, black water urine can be seen. The urine can be black in malaria. But why our answer is G6PD deficiency? Whenever there is a presence of bite cell, what happen in G6PD? You cannot withhold the oxidative stress because the reduced glutathione formation is reduced. Reduced glutathione production will not happen, right? Whenever you have oxidative stress, you cannot withstand the oxidative stress, and so there will be more destruction of the red blood cells, and because of hemoglobin can be denatured, there can be denatured hemoglobin because you cannot withstand the oxidative stress in the G6PD, and this denatured hemoglobin will be beaten off by the macrophage in the spleen, so it will appear like that of bite cell. This is your RBC, and this particular portion appears like that of beaten, so it is known as the bite cell. And whenever you see the bite cell and the Heinz body, the straightforward diagnosis is the G6PD deficiency. So your answer will be G6PD deficiency. MCQ number 4. 30-year patient having the weakness since 4 months. His hemoglobin, hematocrit are low, and the peripheral smear reveal the spherocytes. DCT and ICTs are positive at 37 degree, but not at 4 to 5 degree. The spleen was enlarged. What could be the likely diagnosis? So here the important point is presence of spherocytes, and the hemoglobin hematocrit is low, and the DCT ICT positive. So guys, spherocyte suggestive of some hemolytic anemia. So spherocyte is suggestive of autoimmune hemolytic anemia, or it could be hereditary spherocytosis. But here the DCT and ICT is positive. So the positive Coombs test is suggestive of autoantibodies against your RBC. So it could be the case of autoimmune hemolytic anemia. So until now it is clear that this is a case of autoimmune hemolytic anemia. But again you have to remember that autoimmune hemolytic anemia divided into two types, warm and the cold. In the warm type, the antibody produced at the 37 degree, our body temperature, and in the cold type, the antibody produced against the RBC at the 4 degree centigrade. So hemolysis happen at the 4 degree in cold and 37 degree in the warm. Here ICD positive at 37 degrees. So it is a warm type of autoimmune hemolytic anemia. So now what could be diagnosis? So the diagnosis is the SLE, because The infectious mononucleosis and mycoplasma are the cause for cold type of autoimmune hemolytic anemia, not warm. And obviously, hereditary spherocytosis could not be the answer because DCT, ICT usually not positive in hereditary spherocytosis. So the warm type of autoimmune hemolytic anemia is the causative, and the answer is SLE. Okay, now MCQ number 5. You have the 60-year male patient that is having the enlarged spleen and lost 10 kg weight in a 1 month. The routine blood workup was done, and that revealed the increased basophils in the peripheral smear. In the differential diagnosis also, the basophils were high, that is around 12%. So what can be the likely diagnosis? So here the main clue for the diagnosis is the enlarged spleen and the increased basophil. So these two conditions suggestive of, first of all, this suggestive of enlarged spleen suggestive of some form of leukemia or hemolytic anemia. So we can exclude the diagnosis of iron deficiency anemia. Now there is a presence of increased basophil, and the basophilia, increased basophil is called as an basophilia. It is the hallmark of CML. It is present only in chronic myeloid leukemia. Usually, it is not seen in acute myeloid leukemia or hemolytic anemia. So, your answer will be CML. Whenever the history given of the increased basophil, guys, always remember your answer will be CML. So, this is the case of chronic myeloid leukemia. Okay, now MCQ number 6. OR rod is derived from the which part? First of all, you should be familiar with OR rod. What is OR rod? So the OR rod is a needle-like crystal seen in the blood cells, particularly in the myelocyte. Suppose this is your myelocyte, then there is a presence of needle-like crystal in the cytoplasm of the myelocytes, and that is seen particularly in AML, acute myeloid leukemia. So this OR rod is derived from which part? So it is derived from the primary granules. So your answer will be primary granules of the WBC cell. Usually OR rod is seen within the cytoplasm and it derives from the primary granule, not secondary. Okay, MCQ number 7. The gum hypertrophy is a feature of which of the following FAB type of AML? So this is the French American British classification where M1 stands for AML without maturation, M2 means with maturation, M3 means promyelocytic, and M4 means myelomonocytic AML. When the maturation is increasing, the AML typing number is gradually increasing. So in this case, the maturation is not present. Here there is a presence of somewhat maturation, means in the peripheral blood you can see somewhat promyelocyte, myelocyte, metamyelo. Usually promyelocytes are present in the in approximately less than 10%. When the maturation is increased, there is a presence of promyelocyte. It is the M3, and whenever myelocytes and monocytes also present, it is a type of M4. So the gum hypertrophy is a feature of M4 type of AML. So your answer will be M4 AML. 52. Now MCQ number 8. The 52-year male patient showing the Philadelphia chromosome in his molecular study. What translocation can be seen in such patient? First of all, you should be familiar with Philadelphia chromosome. What is Philadelphia chromosome? So it is the translocation 922 that is known by the name Philadelphia chromosome. Here what happened? Translocation means a portion of one chromosome is transferred into another chromosome. So suppose this is your chromosome number 9, then some portion of the chromosome number 9 will transferred over the chromosome number 22 and chromosome number 22. So it will be transferred over the chromosome number 22, and so this is known by the name Philadelphia chromosome, the translocation 922 is known means the portion of chromosome number 9 will transfer to the chromosome number 22. That is known by the name Philadelphia chromosome, and it is the classical feature of CML. So the Philadelphia chromosome means chromosome translocation 922. So your answer will be B. Okay. MCQ number 9. Identify the cell given in this peripheral smear. So I am talking regarding this cell. Obviously not these RBCs, right? So what is this type of a cell? So your options are early normoblast, late normoblast, intermediate normoblast, or myelocyte. So guys, just see the cytoplasm here is a pure eosinophilic and the nucleus is eccentric. Just see the nucleus is pushed to the periphery. So this particular feature is suggestive of orthochromic normoblast. In the series of the formation of red blood cells, the firstmost cell is erythroblast. Then gradually there will be early normoblast. And from the early normoblast there will be formation of intermediate normoblast. And gradually there is a formation of late normoblast. And then it will get converted into reticulocyte and finally red blood cell is formed. So this early normoblast is having the basophilic cytoplasm and the cell is large. So it is known as basophilic normoblast. In the intermediate normoblast, there is a presence of pink tinge. So it is known as polychromatophilic normoblast and the size is somewhat reduced. Again, in the late normoblast, the cytoplasm is totally pink and the nucleus is pushed to the periphery. So it is matched in this diagnosis. So this given cell is late normoblast. Obviously, it is not the myelocyte because myelocyte cells are large and having the granules. Here, the granules are not present. So, your answer will be late normoblast. And when such late normoblast is increased in the peripheral smear, it is suggestive of hemolytic anemia. Again, it is very important MCQ. Remember, guys, you might be given history that in peripheral smear, late normoblast are increased. So, what could be your probable diagnosis? So your answer will be late normal. So your answer will be hemolytic anemia. In the hemolytic anemia, in the peripheral smear, two classical findings are seen. Remember, guys, it's the most important MCQ. Your late normoblast will be increased, and your retic count will be increased in hemolytic anemia. These two are the classical finding of a case of a hemolytic anemia in the peripheral smear. Increased late normoblast and the reticulocytosis. Okay, identify the mark cell. So I'm talking regarding these cells. Obviously, it is an elongated cell and it looks like a sickle cell. So your answer will be sickle cell. It is seen in case of a sickle cell anemia. So guys, this is all about the today's MCQ. I will cover few more MCQs in my next session whenever possible. If you like my video, subscribe my channel and press the bell icon so that you can get notified whenever I am posting the new video. Thank you very much, guys.